This feed is getting recorded.
Oh, sorry. Okay. I texted Virginia. She said, okay, okay. Devin, Asthma, okay. Devin, 6 years old, 6 years, 9 month old boy from Panapitia. History taken from mother, who is a housewife, educated up to A level. Presenting complaint presented with exacerbation of wheezing. And today is a day two. His representative complaint. 5 days back, he started having cough and wheezing at school while playing with friends. From that day onwards, the severity has been increased over time. He had dry cough, dry continued cough, which worsened in the morning. It has worsened by dust. Mother had given him Piriton. At the time of presentation in ETU, he was restless, uh, which he presented on today morning, that is day two morning, not able to complete a sentence and had no cyanosis, and oxygen saturation was 88 according to the mother. Therefore, it was severe exacerbation of the asthma. The first episode was at the age of 5, which was in 2024, uh, with cough, wheezing, shortness of breath, and chest tightness complaint. He also had atopic dermatitis. He had 5 attacks since then, and for 4 times he had been admitted in hospital and nebulized. From his last attack, that was on September 2025, he was started on inhaler, salbutamol, and ipratropium. He had good compliance to it. Child has uh, more than 2 episodes per week during per yeah two more than 2 episodes during day, and uh, he was well in between the episode. This time on the morning of day one, his mother had forgotten to give him inhaler. There were no history of any contact or any past cardiac history. Past medical history, as mentioned above, and past surgical, there were no significant surgical history. Allergic history, there were no food, drugs, or plaster allergy. Immunization was up to date with his last vaccine was OPV and DT. Now, developmental history, child is performing well in his school. Family history, this is the family history. This baby have elder brother and sister who are 12 years old sister and 10 years old brother, and his sister had his older sister had asthma, for which she was treated and is in inhaler as uh, uh, SOB. Mm, Social history, father is a carpenter and mother is a housewife. After the disease, uh, the baby had missed school every time he got admitted. There were no outdoor playing restriction, and teacher is well informed about the child condition and she is supportive. Father's monthly income is around 50,000 per month, which because 50,000 per month, and child's condition has significantly affected their social economic condition. Other siblings are being looked after by the grandmother when the child is admitted in the hospital. And if I talk about their environment, they live in their own house with 3 bedrooms and a carpent. The father works on just beside the house from where the dust are coming inside the house, and even the mother clean the house, sweep the floor every morning and evening, and mopped once a week. Still, it is still the dust are coming in. They do have windows and ventilation. Mother changed the bedsheet and pillowcases every 3 days. Um, and they use gas to cook. They don't use any mosquito coil or any mosquito coil, or they don't have any pets. Um, there are no any smoker at home. They have enough family support, extended family support, and the nearest hospital is in Panapitia. Mother do have knowledge about the disease, and yeah, and how to recognize the acute exacerbation and what to do. And she do know how to use inhaler device, and have good compliance, but sometimes she do forget. Mm, if I talk about his examination, he was general examination. He was well looking guy, a well looking boy. He's 16 kg, 300 gram. His height was around. Okay, I didn't write the height. Um, on my examination of RS, uh, there were no any oral thrust or in mouth and throat. There were no cervical lymphadenopathy or clubbing, and there the BCG scar was present. There was no ankle edema, but there was atopic dermatitis scars. Um, yeah, on auscultation, I could hear ronchi bilaterally. Mm. And CVS, his heart rate was 80 beats per minute. There were no uh, added sounds. And abdomen, there was no any organomegaly. CNS examination was insignificant. Yeah, that's it for history
Okay, summary and problem list.
summary. This is a 6 years, Devi, 6 years, 9-month-old boy. History taken from mother, presented with exacerbation of wheezing for which started 5 days back. He is currently on salbutamol and ipratropium bromide. This time, presented. Oh wait, nine. Okay, my summary is not clear.
Okay, problem list.
Problem list: uh, medical problem, asthma, acute exacerbation of multiple episode, and then no um what proper, what is it like? The mother keep on forgetting about inhaler, and social problem is the father working just beside the house, because of which the disease is getting exacerbated.
Okay, and your management plan.
Management plan, since he management of this now, or
Yeah, management of this kid.
so he presented with acute exacerbation of mild persistent asthma, which is my DD
Why did you
diagnosis.
say mild persistent?
Yeah, he used to get more than 3 episode per more than 2 episode per day, and but less than 2 episode in a week
Mhm.
per night. Yeah.
No, let's consider the last week. So over the
Uh,
last week, how
mm,
many daytime symptoms? How like what is the frequency of daytime symptoms and what is the frequency of nighttime symptoms?
the last week after, okay, that was more than two
Okay,
per in a week, and but
okay.
night time it was not there.
No, no, no night symptoms at
No
all.
night symptoms. Yeah.
Okay, so we
After they
where
started using the inhaler,
okay. Okay, so where does he stand in the step up ladder? Step one or two or three or where?
step one.
No, now you
Step
said
two. Sorry, step two. Sorry, step two.
okay. So step two, is it mild intermittent asthma or what?
It is mild persistent. He had more than two per week, but mother said in last 1 month he did had at night also, like few times.
Oh. Is it mild persistent or step two? Is it mild persistent? Because I can't remember.
Yeah, no, mild intermediate is step one.
Yeah, 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 yeah.
Mm,
Yeah, this is step two, right? Mild
yeah,
persistent. I think.
yeah.
Okay. Yeah. So, okay. So go on the problem list.
That's it, my problem list.
Okay. So the management plan? No, I
Manage,
went the management plan to the problem list. Each problem. So the if the patient presented acutely to the ETU.
then I will start him with, I will connect him to the monitor
Mhm. Okay.
and then check his oxygen saturation, and uh, then we have to see the severity of the severity of the episode, if it is whether it is moderate, severe, or life threatening. So
Mhm.
there are a few points we have to see to differentiate it. Mainly the oxygen saturation. If it is less than 92%, then it is severe, and if it is more than less than 85, with if the baby is cynosed, drowsy, then it is life threatening. Since this baby was restless at the time of presentation with 88% of oxygen saturation, then he is severely exacerbated. So for that I will nebulize, put him on the oxygen, give him oxygen through face masks, 8 to 10 liters per minute, and then start him on salbutamol, nebulized salbutamol, zero point 0.5 ml, no, zero point 0.5 ml, no, 1 ml,
0.5 ml or milligram. Yeah, 1 ml and
1
zero point
ml,
5 milligram, right?
yeah, 1 ml into ml of normal saline with
Only
oxygen.
salbutamol.
And if, huh, at first salbutamol, no,
Yeah, only salbutamol or what?
with normal 2 ml of normal saline with oxygen.
Why IPRA?
I didn't say EPRA.
Do you need IPRA now?
We give EPRA in the first episode itself.
Yeah, yeah, no. This is an acute CV exacerbation. No? So
Uh,
are like some say you don't need to give IPRA, but yeah, just mention IPRA. So what is the dose?
uh, EPRA point 5 milligram.
Yeah, 500 mics. Okay.
Uh,
In ml?
0.25 ml.
No, 1 ml. Ne? 1 ml cell and 1 ml IPRA.
Okay, okay. That is confusing. Okay.
Okay, just check, right? Because I also can't remember and I don't have my note also with me. Okay,
Uh,
then
okay. And then we have to give him back to back nebulization for 3 times. Um, and then after that,
okay, so you are going to give the same medications for 3 times or what?
yeah, same medication. No?
No. So the first 10, like some say you don't
Hmm?
need to repeat ipratropium 3 times. Some give ipratropium in the first and the third one, and they don't
Oh,
give it to the second. Some give only to the second nebulization, right? That depends on the unit policy. But just keep in mind that you don't need to give IPRA like in each and every nebulization. Okay.
okay. And when do we give hydrocortisone?
Yeah, you
I,
should tell them. Okay. Why do you need to give hydrocortisone to this child or prednisolone according to the mother?
he was drowsy, so I will go with IV hydrocortisone.
Okay. Well, then was he cynosed also?
No, he was not cynosed.
Okay, right. Okay, then continue in the
Uh,
management. Continue the management.
and then after back to back, I will assess if there is no, if there is poor responding, then I will go with IV IV magnesium sulfate, 40,
Dose.
40 milligram per kg
Okay.
for 20 minutes. Uh,
Okay.
and then still, if that also doesn't work, then IV aminophylline.
Will you give the loading dose or not?
I have to give because he was not on aminophylline previously,
Okay. Okay. Yes. Brilliant.
and then
Okay. Then.
uh, if that also doesn't work, then IV salbutamol.
Yeah, yeah, yeah. But before you are giving aminophylline, you need to tell, I will get the senior opinion, admit the
Mhm.
child to the ICU.
Okay. Hello.
Oh, hello. Yeah, I keep getting disconnected. Okay, so you need to admit the child to the ICU, take the chest
Uh,
X-ray, do the ABG, and then only you will start the aminophylline and second line medications, right?
for magnesium sulfate, we don't have to do that, right?
Yeah, magnesium sulfate you can do if they are, right?
Mm.
So, okay. So, what is the reason for the exacerbation?
Other he was playing, so he was playing football. So there were dust and all. And after coming home, also the carpentry work.
Yeah,
It's just
so so you have tell it is dust and
mm,
exercise. Okay.
okay,
So dust and exercise and maybe cold air. Like you can tell he was playing football in the morning, so there's cold air also, right? So you
okay.
had identified three factors, right?
Mm,
Okay, so your history was okay. It was brilliant. Okay, and
okay.
right.
Uh-huh.
So, but the thing is, like, I like little bit of things, right? First one is like in the introduction, you could have talked about the mother's level of education. Like, she's having very poor knowledge now.
Yeah.
I don't think she knows about the risk factors properly, and she's not aware of using the inhaler with the good compliance. So, you could
Mm,
have mentioned that in the introduction, like, you can tell the mother is educated up to A levels or whatever, but no, like, very poor knowledge about the child's condition, right?
okay.
Right. So, is this asthma?
Yeah.
Why do you say so?
Uh, there is a family history. There is a trigger. There is a history of atopic dermatitis.
Hmm.
And it is mostly severe in the morning. There are no history of
Okay,
any other
you tell it's diurnal variation in the cough, right?
diurnal variation in the curve. Triggers
Okay.
were there: atopic dermatitis, family history, sister had it, and there are no
Yeah.
other. Other.
Other thing, response to salbutamol, right?
Yeah. Okay.
Okay, so salbutamol response is also there. So this is asthma. That is fine. Now let's
Mm,
say this child comes at the age of 4 years, right?
okay.
Okay, so 4 years, and is this asthma now?
Yeah. 4 years also still asthma, no?
Why?
Uh, Up to from like below 2 years only, we can't say whether it's asthma or no. I'm not sure.
So, do you know like about okay? So, like it's like this. Now you have to know something called asthma predictive index, right? For this child, it is
Mm,
not applicable, but
mm,
because like in the past long cases, they have like frequently questioned about asthma predictive index. So I'm just telling you. So
mm.
in asthma predictive index, so there are major and minor risk factors. Okay, so there's a stringent
Okay.
asthma predictive index and a loose asthma predictive index. There's a little bit of a variety. So there are
What? Can
major
you repeat? What did you say?
the stringent API and loose API killer, there's a
Uh,
variety of asthma predictive index. Okay. So there's a
okay.
major and a minor criteria. So in the major criteria has two things. One thing is asthma in a parent that is documented by a physician, or eczema in the child which is documented by the physician. So this child had atopic dermatitis, and like you could have told like he was diagnosed with atopic dermatitis in a clinic, right?
Mm,
So it is
yeah.
like, so to make sure that it is documented, I don't think like you need to mention these things. Your history is very good, right? So then
Mm,
the minor criteria has three things. One thing is allergic rhinitis in the child, allergic
mm.
rhinitis, and then wheezing apart from cold, and other thing is peripheral eosinophilia, right?
Okay.
This is the major and the minor criteria of asthma predictive index. and this is applicable for in a younger child, right? Not to your
Mm.
one, okay?
Okay.
And the stringent API has more than 3 episodes of wheezing per year during the first 3 years, along with one major and two minor criteria. Okay?
Okay.
So if the child, you had checked whether the child fits into stringent API, and the loose API is where you have fewer than 3 episodes with one major and two minor criteria. Okay?
Okay.
Right. Now, if for this child's acute presentation,
Mm.
what are the differences that you can come up with?
Obviously, bronchial asthma.
Okay.
Mm. Foreign body aspiration. Oh, foreign body inhalation.
Okay, but okay.
Uh, uh,
Yeah,
TB.
foreign body. TB.
TB.
It's acute. No, eh?
No, no, no. Heart
Okay.
failure.
Yeah, heart failure, fine. Okay, then.
Mm. Then I don't know.
Yeah, so you can have told about this chronic upper airway cough syndrome.
Okay.
They have this sneezing, itching, blocked nose, those things. And
Mm.
inhale foreign body, you can tell that is fine, right? And
Mm.
if this patient's asthma is poorly responding to the medication, now let's assume that the mother's compliance has been good.
Mm.
So if the patient's asthma is poorly responding to medications, what are the other differences that you should consider?
Poorly responding, then it might the choice of drug is not correct or the dose is not enough.
So what is the no, no, no. Let's say the dose is correct, the drug is correct. Any drug in the sense like this albuterol, there's no any other drug. So
Mm.
the baby is receiving salbutamol. What are the other differential diagnoses that you will consider at that point?
Mm. Mm.
The
Don't.
child was getting these recurrent episodes, right? And child
Mm.
is in your ward. So what are the other differentials? Poor response over 1 month, let's say.
Bronchitis.
Yes, one thing. Any other thing?
What about bronchiolitis? But I don't know about that.
Bronchiolitis at this age?
Oh, okay, it's a small baby, uh don't know city.
Yeah, so you have to go with mainly like one is bronchiectasis. Okay, so
Mm.
they will have productive cough and recurrent infections. Other thing is don't forget TB, right? So you have
Okay.
to ask about contact history, like these loss of appetite, loss of weight, those symptoms, fever, night sweats, those symptoms, right?
Mm.
And hemoptysis will be there. And the other thing is like things like primary ciliary dyskinesias where you get recurrent infections, productive cough and sinusitis. And
Mm.
then you can also consider about this congenital heart diseases. We like to check whether the child is having any murmurs there, right? So that
Okay.
is one thing that you have to. Other thing is your description about inhaler technique was not that good, right? So whenever you are telling about some patients inhaler technique, go in
Mm.
order, right? So
Okay.
like what I used to do is like I have a certain like I had 7 points.
Okay.
I check for inhaler technique and I comment on these 7 points in every child with inhaler technique, so I don't miss anything, right? So
uh,
those 7 points are one thing is position in the child. So the child should be positioned. So like in the sense that if this child has to be seated or stand in position, either is fine, but
mm.
child's back should be upright. Okay.
Okay.
And then priming of the inhaler, whether they prime the inhaler properly or not, right? And
Okay.
then next thing is lung emptying prior to inhaler, right? So whether they do it or not. And then you have to assess the adequacy of seal between the face and the mask or face and the whatever the device, MDI or whatever the device you have to take.
Mm.
Okay. And
Okay.
then because they will have that maker will also be there. මොකක්ද අර
Spacer.
spacer Patient, yeah. So you have to talk about the number of breaths they are taking. Usually, if they are taking around 5 or 6, around 10 breaths a tonani. So,
Mm.
like you have to count the breaths and tell whether it is adequate or not. Okay. Then
Okay.
I talk about the aftercare also within the inhaler. One
Mm.
thing is cleaning the device, and the other thing is wiping the face and rinsing the mouth with water. Right? Wiping the
Okay.
face is applicable if the child is having a face mask.
Mm.
Otherwise, you don't need to wipe the face, but rinsing the mouth with water, that should be done. Okay.
Okay.
So don't forget these 7 things and comment about the inhaler technique under these 7 things. Okay.
Okay.
Right. Okay. Right. Now, let's say other thing is now, like this sort of a patient surgery කියනකොට you can tell like pneumothorax වලට IC tube, no IC tube insertions for pneumothorax කියලා, no past surgical history is not significant, no surgeries for IC tube insertions. So ඔහොම කියලා මොකක් හරි කියන්න පුළුවන්, because you have to go like always put something that is relevant to asthma. Okay.
Okay.
And may vaccine history කියනකොට, like as I mentioned previously, you have to tell no additional vaccines, such as like you can tell about influenza and pneumococcal vaccine to this child. And
Yeah.
usually they don't get anything, no. And
Yeah.
you have to tell the last vaccine and you have to tell the next vaccine due date. Okay. Right.
Okay.
And the development history, yeah, that is fine. You mentioned schooling because it's a 6 year old, no point in breaking it down to like that, no. That is fine.
Yeah.
And other thing is, yeah, about the social history was also very good. So the environment, you can like it was very good, but I will also need to add like when you are telling the environment, you spoke about that the father is a carpenter and father's workshop is somewhere there, Kayla. But
Mm.
in addition, you can add things like the distance from the main road to their home, right?
Okay.
Whether they are
Okay.
living next in a like next to a road with full of dust and all those things, you can tell. And if there is a nearby factory which is producing a lot of fumes and all, you can tell.
Mm.
Okay.
Okay.
That is about the outside environment. And also about the environment, you can talk about the other components. Like here you had a very big problem with the carpenter thing, so you
Mm.
like these things will not be noticed by the examiners. But like if for anyone, like if so let's say in the exam, if you get a normal patient, you can comment
Mm.
about the roof, right? So whether they have a ceiling in the roof or whether it's just that whether they don't have a ceiling and it's those asbestos sheets that will cause like worsening of these dust and exposures, right? And then you
Okay.
can ask about the flow, whether the flow is cemented or whether the flow has tiles or whatever the thing, like because that will add on dust now. And then kitchen, you ask correctly about whether they have these cooking fumes and where it is. And chimney, whether they have a chimney killer, you can mention. Okay.
Okay.
And other thing is damp walls, right? So in the
Mm.
toilets and all, they if their walls are damp, they get this aspergillosis and all those. Not aspergillosis, they like these fungi. They try to stay on the walls and they will produce spores, which will cause asthma. Okay. And
Okay.
you correctly mentioned about the pets, right? So it's mostly
Mm.
the cat. And the cats may not the cats, it's not the cat fur, it's the cat saliva which matters, right? Right. And if
Ah.
this family has sofas or something, you can ask whether the sofas are kept covered or not, right? And other thing is you have to ask about the cleaning of the house. Like
Mm.
cleaning in the sense when they broom or sweep or whatever, like
Mm.
do they keep the doors and windows open or do they keep them closed? And they like and you can ask about at what time does the mother sweep the house, right? So at
Mm.
that time, where is the child, right?
Okay.
Those sort of things, I don't think like when you present a see the social history up to your extent, like they will question. But I'm just
Uh,
telling, right? And
okay.
then smoking and all, you said there is no this thing, right? So and like Sri Lankan carpenters usually earn more than 50K per month, right?
More than that.
More than 50 Sri Lankan carpenters will earn, right?
Oh,
Uh,
I that.
I don't know about Bhutanese ones. My other
I
thing
don't.
is, right? Other thing I saw is that you mentioned the past medical history. So
Yeah.
there, did you say talk about ICU admissions? No, right?
There were no ICU admission. Only what?
Yeah, did you tell that?
I didn't tell that.
Yeah, okay. So you can tell that. And other thing is the allergy history. So allergy history has to be mentioned,
Yeah,
right?
there are no allergies.
Yeah, yeah. You have to tell, like, because atopy is another problem that these asthmatics tend to have, no?
Yeah.
So you have to mention about that, right?
Mm.
Um, yeah, that's all. Your history is very good. So yeah, nothing much to comment also. So basically, you followed all the components. So
Mm.
when you are telling about the history of presenting complaint, that is fine. So like for me, I will also like if you tell. Did you tell there is no fever?
I didn't tell that.
Yeah, because you need to tell that there is no, this is not an infective exacerbation of asthma, right?
Uh-huh.
So you can tell like, so when you are telling, this is like you said, this patient presented with wheezing, that is fine. But they,
Mm.
like, when did you tell it is cough and all that?
Yeah, in HOPC I told.
Okay. So wheezing and cough, right? So you
Mm.
could have brought the cough up to the PC also, right? So
Okay.
then you, when you, because then you can analyze the cough a little bit more, like we about the diarrheal variation, whether it is a productive cough, right? That has to be mentioned now.
Yeah.
And then the cough associated with wheezing, and you can also talk about chest tightness, shortness of breath. Those
Mm.
things you can mention. Okay, so
Okay.
that part was very nicely done. And
Mm.
then and then you have to tell this is not an infective exacerbation, right? So you can tell no prior history of fever or cold or upper respiratory tract infection. So throat cold or upper respiratory tract infection was also not there. You can
Mm.
mention, okay, in the HOPC, right?
Okay.
So after that, like this child has had the symptoms when the child was there at home, ne?
Yeah.
So over that period, so like prior to this episode, child the status of the asthma you can mention like that. So during this episode, when the child was at home, you can talk about the gradual worsening. Like in the sense now, if this mother has brought the child to other private nebulization centers and got the
Uh,
child nebulized from those places, you
uh,
can comment on those also, right? So
okay.
prior to getting admitted in the hospital, the child mother has taken the child to the nearby nebulization centers and got the child nebulized. And
Mm.
eternally, you can tell, however, at those instances, the child was not drowsy up to this extent. Okay. So
Okay.
drowsy, lethargic, like unresponsive වගේ
Mm.
වෙලා
Mm.
so Eva, you can tell like that it was not there. So so that will give the impression that those episodes were around moderate to severe exacerbation of asthma. But this episode is life threatening, no severe or whatever. Like you want to imply, you can like are according to that table, make
Mm.
sure that they get the idea that the severity of these two conditions are different and the
Mm.
management has been different, and you are aware of that condition. Okay. Right.
Okay. CD.
So,
So we have to tell no severe exacerbation of mild, moderate, or like moderate, persistent that asthma. So for that to differentiate
no,
it to
no,
mild, moderate, this thing
moderate persistent that comes under there. That is not for this episode, no.
that
So, like
for which episode? That's what I
that
wanted.
is for the like that routine step up care. Like this here, you have two things. One thing is the step up care management,
Mm,
which we call this mild intermittent, mild persistent, moderate.
mm,
එහෙම යන්නේ, that
mm,
is the like general plan for the child when the child is at home, right?
mm.
So this one, these are a moderate, these are severe attacks, right? Sorry, acute exacerbations, no, what you
Yeah,
are
yeah.
trying to say. So you get the difference, right?
Yes, yes, yes. Now I
So
got.
so in the past medical history is where you talk about the step up care to imply the
Ah, okay.
level of the management of this child,
So
right?
that should be just before this episode thing. I have to talk about just before this
Yeah. So
episode, right?
before this child went out and played football,
Ah, okay.
right? Now after child went out and played football, and can a 6 year old play football? Okay. So
I
then
don't know, man. He said he was playing something. I don't know what he was playing.
yeah, okay.
Mm,
Then you can talk about the severity of the exacerbation, acute attack. Okay,
mm,
Okay. Then where will yeah. So then you can talk about the acute attack. So you can even tell the child was, however, after the initial therapy, child responded, right?
Mm.
So then no needed to intubate, right? Those things you can tell. Because in asthma, unlike in COPD, their threshold for intubation in asthma is very low. Like the moment they get worse, they intubate. But in COPD, they don't intubate that fast. Okay?
Okay.
Right. So, right. Other things are, yeah, those things are covered basically. Yeah, nothing much to comment. Your history is good. And you need a little bit of improvement on the management plan, right? So, acute
Yeah.
management, okay, fine. But just tell me about the step up care. How will you manage, do the step up care?
Okay, that
If
is
it is,
confusing. I also step step
so,
one. I don't know CD. Like I'm really confused about that.
yeah, so it is, if it is step one, that means there is no wake night symptoms,
Mm.
only daytime symptoms, but daytime symptoms are less than twice a week. So
Mm.
you usually treat them with low dose ICS and SABA as needed, right? Both ICS, low dose ICS and SABA SOS. Okay. Then you have step two care. Step two is where they have daytime symptoms, 2 to 5 days a week, along with but no night symptoms,
Mm.
right? So
Yeah.
this one is the symptoms, daytime symptoms are very mild and they are not affecting their daily activities. These
Okay.
patients will need daily ICS and SABA as needed, right? Then
What
you have
about the first one? First one is also same, no?
no, it is ICS and SABA when SOS.
Okay.
Here,
This.
ITS daily and SABA SOS,
Okay. Okay.
right? So in
Mm.
step three, they have symptoms most of the days
Mm.
and night symptoms in the sense they should wake up at night due to the asthma.
Okay.
And that should occur once or more per week. Okay.
Okay.
So these people will need low dose ICS and SABA daily, or they can go to a medium dose ICS and as needed SABA. Okay.
Okay.
And level 2, 4 is where they have daily symptoms, daytime daily symptoms, and night symptoms once or more per week. Right? Daily
Mm.
symptoms, like daily daytime symptoms and night symptoms once or more per week. Right? They are, of course, like you can talk about this medium dose ICS, LABA, right? And from step 3 onward, I can't remember LRTI කොතෙන්ට දාවේ කියලා. So LRTI is also there. They are for add-on therapy. You can talk about the LRTI, LAMAs, long-acting like tiotropium is a LAMA, right? Those
Mm.
things. And you need to talk about the step down also, whether this child has had a step down. Like if the control is maintained for 2 to 3 months, then you can consider doing the stepping down. Okay,
Okay.
right. Now, yeah. So, about the spacer care.
Mm.
So spacer from where are they getting the spacer? Probably from the hospital name.
I didn't ask that.
Yeah. And how do they wash the spacer?
Okay, that also I didn't ask.
So yeah. So the important thing you need to ask is like they
Mm.
should wash the spacer only once a week again, right? Not daily. Definitely not daily. Once
Mm.
a week, and they should not touch the inner part of the spacer, right?
Okay.
So they shouldn't even wipe that inner part. What they should be doing is like they can dissolve a detergent or soap in a water and like they should soak the spacer into that container, right?
Mm.
So like and they can like then rinse the spacer in like this flowing water. They should not touch the inner part, right? That is the most important thing,
Okay.
right? Um,
And air dry it, right?
yeah, and right. So uh, okay, then about the breath techniques, I told no, like
Mm.
usually you need to count the number of breaths the child is taking, right? So
Yeah.
because that is multiple breath technique. Now, if it is an adult, you can go for the single breath technique also, right?
Okay.
Single breath technique is like they take one breath and hold it over 10 seconds and slowly exhale. But a
Mm.
child can't do that, no. So
Yeah.
therefore, child is asked to breathe normally, like 5 to 6 times. They can go like maximum is around 10. Like
Mm.
so, like they will be breathing in their tidal volume. But if you go for the single breath and hold technique,
Mm.
they will have to go to that inspiratory reserve volumes. Okay.
Okay.
Mhm. Yeah. Yeah, I mean that's all, no? I think your history is very good.
Okay.
Um, and the management plan was also like considerably it's okay.
CT for
Yeah.
examination apart from what inhaler technique, what else we have to check? Rest be okay, and then like what are the findings?
The growth parameters are very important because like if they have been on steroids, you can talk about like in the general examination, I used to say there are no features of cushingoid phases or something.
Mm.
Like not the inhaler ICS inhaler steroid won't pose that harm, but
Mm.
if they have been on oral prednisolone repeatedly over a like period, they can be cushingoid, no?
Yeah.
So you can tell that, right?
Okay.
Uh, yeah, I can't remember anything else. Yeah, that's all, ne?
Okay.
Yeah, because your history is also good. I don't have anything much to discuss. Okay. Okay, then. Bye.
Bye.
Bye
Thank
bye.
you.